we saved the best for last. Our next speaker is Dr. Alex Tuchman, who is the spinal deformity surgeon at Cedars in LA, where everybody is offered a 5-level lumbar disc, and he's telling the patient they need a teeth in the pelvis. So he's going to talk about posteriorly based osteotomy to correct spinal deformity.
I'm one of the few doing fusion still in the city of Los Angeles, so sort of the youngest dinosaur at my hospital. All right, so this talk is going to be basically that population of patients that we know they have a spinal deformity. You've kind of committed to doing a big reconstruction. There's going to be a posterior component to that, and you're going to have to choose your osteotomies, basically posterior column osteotomies versus doing a 3-column osteotomy. And so just for nomenclature standpoint, for posterior column osteotomies, we're going to be talking about pretty much the Schwab type 2 classification. And then for 3-column osteotomies, it's really depending on the anatomic needs, but you have your pedicle subtraction, VCR, and VCR type osteotomies. So posterior column osteotomies are posterior shortening procedures, generally about 10 degrees of sagittal plane correction, though oftentimes in the thoracic spine, you're going to get significantly less than that. And historically, the Smith-Peet or Ponte osteotomy as well, kind of used interchangeably. And the fact of the matter is they're effective. They increase flexibility of the spine, and they're relatively safe. Low rates of neurologic complication, and especially compared to 3-column osteotomies, significantly less blood loss. And with well-planned posterior column osteotomies and flexible deformities, you can get large corrections. And even in cases with previous fusions or attempted fusions with pseudoarthrosis, posterior column osteotomies planned above and below, you can get adequate correction of a spinal deformity without having to commit a patient to a 3-column osteotomy. But in some scenarios, really, multiple posterior column osteotomies are just not going to cut it, pun intended. And so in those scenarios, we have a 3-column osteotomy where you can get much larger corrections, but that comes with a significant trade-off, right? You're going to have significantly more blood loss with these types of approaches, high rates of neurologic injuries and pseudoarthrosis and reoperation, and also the concern of overcorrection, which can lead to postoperative complications as well. But there are some scenarios where a 3-column osteotomy cutting through a previous fusion mass when the generator of the deformity is within that fusion mass may be your best option, even without a very severe spinal deformity. In other cases where vertebral column resection for a major deformity is going to be your best tool. But when do you really need to use it? What scenarios are going to be the best for multiple posterior column osteotomies versus cutting the 3-column osteotomy to really increase the flexibility of the spine? And so there's kind of 3 major categories that in my mind that I kind of go through as a checklist to try to help with my surgical decision planning. And the first one, and probably the most intuitive one, is flexibility, right? So the amount of flexibility you have going into the surgery in the spine really gives you probably the most information about whether you're going to be able to correct this without having to cut a 3-column osteotomy. I think the rigid group is really the one with the most equipoise, where it can sometimes make the decision-making the most difficult. So I like kind of 2 similar-looking anatomic deformities, right? But in reality, these 2 could not be more different, right? This one, on the scout view of the CT scan, you can see basically completely corrects when the patient lies down for their CT scan. And so you kind of know going into this, you're going to have a pretty easy day. You're going to get a very good correction. In fact, the main thing you have to worry about is not overcorrecting a patient like this, right? And so that's where actually the utilization of pre-bent rods and things like that have been huge in my practice, although this was a little bit before that. This case, on the other hand, this type of patient is not even going to fit in the MRI, can't get an MRI, right? Very rigid, and you kind of know going into it, this is going to be a very long day. This is going to be a very difficult surgery. You're definitely going to have to cut a 3-column osteotomy in order to get this type of a correction from a surgery like this. And that's based on the flexibility. What about the cases where you can create some flexibility, sort of these rigid cases where it's not really flexible to start, but with posterior column osteotomies, you may be able to create rigidity. So again, kind of twin looking, preoperative x-rays, but again, they're also very different. So this one here, we can see that is a solid posterior lateral fusion, but open disc spaces. In this case, this is a multi-level non-union from a multi-level T-lift. There's a sacral insufficiency fracture as well. They took the screws out. It's technically mobile. It's a pseudoarthrosis, but how we're going to try to correct these cases are a little bit different. In this case, I cut through the previous fusion mass with posterior column osteotomies, then used some A-lifts to kind of help mostly from a fusion standpoint with one screw going either up or down, so I could then close the posterior column osteotomies from the back and get good overall alignment, kind of transitioning this to a very flexible curve from a rigid or fused one. And in this case, that type of technique just seemed too difficult to take out all these interbodies from the front and instead cut a 3-column osteotomy at L4 in order to get similar correction. The next issue is bone quality. And the reason why bone quality is so important in the decision making is, in general, if you're going to do a multiple posterior column osteotomy approach, a lot of times you're going to have a longer lever arm, and you're going to be transmitting a lot more force through the screws because you're working through disc spaces rather than completely disarticulating the spine and letting it fall into deformity correction like you get from a 3-column osteotomy. There's a variety of ways to assess bone quality, but in some scenarios, like a case like this, I think highlights why it's so important. There's a patient that was myelopathic and really needed to be treated predominantly for the myelopathy symptoms. In my hands, I decided to do a costotransversectomy, but also had this thoracolumbar kyphosis non-union. I felt like I could also correct their sagittal plane deformity at the same time with posterior column osteotomies. And in the immediate post-op x-rays, I couldn't have been happier with my result from a myelopathy and upright standing standpoint. But there's a lot of force on a construct like this, and sometimes half measures do not end up with good short-term outcomes. So it comes back to my office 2 months, can no longer stand up straight, severe back pain, and ended up having to cut through his previous fusion mass, which had now partially fractured, and cut a L4 pedicle subtraction osteotomy to improve his bone quality. And as has been highlighted kind of multiple times, now that we have anabolic agents, we can really improve our outcomes with these. Teriparatide has been shown to increase insertional screw strength, decrease screw loosening, increase fusion rates, and then newer agents like Avinity have also been shown to be anabolic in nature, low risk of vertebral fractures, and some animal models also showing better fusion rates with these medications as well. So that's something in our toolbox that we can preoperatively kind of change the patient's morphology and maybe make them a candidate for a less aggressive surgery. The next alignment consideration, in my mind, when making the decision between that, is the angularity of the deformity. The big part of this is in general, kind of a short angular curve in most scenarios is more likely to need a 3-column osteotomy for adequate correction versus long sweeping curves. You can typically get away with multiple posterior column osteotomies in order to get similar correction techniques. If you want sort of an objective measure of the angularity, the deformity angular ratio is helpful, although originally described for predicting neurologic deficits. Angular sagittal deformities are a little bit more dangerous than coronal ones. And so kind of to highlight that, this 80-degree coronal curve over multiple levels is certainly a less risky surgery, and one that you can, even though technically the curve on this curve here is a 60-degree curve, right? In order to get adequate correction, the techniques would be very different. So multiple levels, deformity angular ratio of 16, and in the coronal plane, and so with posterior column osteotomies, able to get a very good correction, versus this short angular curve, a vertebral column resection was a more appropriate approach. Finally, in terms of alignment, and probably one of the more important aspects is where you're going to place the lordosis within the spine, right? So more and more data coming out that it's not just getting the head above the pelvis or getting PI and LL to match, But actually where the lordosis is placed has a significant effect on or postoperative complications, instrumentation failure. And so when we're talking about regional lordosis in the spine, this study, and I think I've seen the means data get presented at meetings a couple of times, though I don't think the actual publication has come out yet. But L4 to S1 is pretty standard across pelvic incidence. So about, depending on the paper, like 35 to 40 degrees, L4 to S1 on average in most patients, right? And so the difference actually in the lumbar lordosis from patient to patient as determined by pelvic incidence is really all in the L1 to 4 level. So a patient with high pelvic incidence really needs a lot of lordosis at L1 to 4, while L4 to S1 should typically be the same as a low pelvic incident patient. The difference is that low pelvic incidence patient has should have very little lordosis at L1 to L4. And this is in a more complex way of understanding it. This is sort of the same thing that's being said in the Rousseli classification from, years ago, right? And so it's the same basic premise, right? The high PI patients have more curvy spines, and where the apex of that lordosis is going to be is determined because no matter how high the PI is, that first takeoff, L4 to S1, is about that 35 to 40 degrees. And so why is that important? Because spinal shape has a significant effect on proximal junction kyphosis instrumentation failure in studies that have been shown so far. So in the Rousseli classification, higher rates of proximal junction kyphosis when cases were not corrected to the theoretical apex of lordosis. In the ISSG data set, also they found that PJK was associated with cases where L4 to S1 was relatively kyphotic and lumbar lordosis was restored in the more cranial T12 to L3 segments, right? GAP score includes the distribution of lordosis index within it, showing mechanical complications are significantly more likely when the lordosis distribution index was greater than 80 or less than 50, which basically means that this mismatch here, this is tagged, right, is one that kind of, basically it's the same pattern, just described a lot of different ways, right? And so kind of using these alignment predictors and things like that in terms of trying to decide where you're going to put the lordosis back into the spine during deformity correction, at least within the GAP score predictions, they found very high rates of being able to predict who was going to have mechanical failures. Now, there are caveats to that, okay, because that was then validated within basically the same data set that it was created in. Other deformity series have not kind of shown the same strong correlation with GAP scores, but I think there's enough evidence of the underlying principle that regional alignment is something that we need to pay closer attention to, and how that affects our deformity correction techniques and where we're going to be getting our correction, I think is helpful. And so there's kind of two curves that I see often in at least in my practice where this comes up. And again, we have kind of twin deformities here with severe thoracolumbar kyphosis and kind of trying to compensate above and below, right? And so if we're going to try to sort of restore lumbar lordosis to our target at L1 to L4 and then kind of keep our matched L4 to 5, our choices in osteotomies are going to be very different for these types of patients and how we're going to do it, right? And so certainly we can do other constructs where we don't try to restore these alignment characteristics, and in some situations that may be the better option if it's too morbid to do a larger surgery. But this was a relatively flexible curve, able to get correction sequentially and correct with PCOs alone through the thoracolumbar junction, and then keep the distal lordosis kind of at its target. Versus in this case, this patient actually had previously had Harrington rods from a fracture. He had a fixed deformity at the thoracolumbar junction, and so used a mixed technique in a case like this, where I cut a 3-column osteotomy at L1, got back to the target lordosis at L1 to L4 based on his pelvic incidence. And then because he was compensating both above and below, I actually used posterior column osteotomies to pull some of the lordosis out to restore his regional alignment and prevent myself from overcorrecting, which can oftentimes in situations like this be an issue. So then the second thing, and I kind of, in this case, I did 4 sagittal x-rays. The other issue that we see quite often is when L4 to S1 is flat, right? So now we have kind of less than that 30-degree target. This case here was a discectomy gone wrong 30 years ago with osteodiscitis, and this is actually L4 and L5 fused together in kyphosis. This is a patient marching up with progressive adjacent segment disease, and all 3 of these are actually marching up cases with progressive adjacent segment disease, where the primary insult was that the L4 to S1 lordosis was kind of made flat from the beginning. And so if you listen to the data on this, it would say that we should be cutting pedicle subtraction osteotomies, through all of these to get the correction and the regional lordosis to kind of decrease mechanical complication numbers. Now, that comes with the caveat that we know that cutting 3-column osteotomies are certainly higher risk. So weighing that risk-benefit calculation is going to be very difficult. And certainly, I think we all have cases where we didn't kind of restore the regional lordosis. We got the correction in non-physiologic locations, and we have long-term outcomes where patients are doing spectacularly well. In this case, for example, she was autofused through her entire thoracic spine, so I felt very comfortable kind of with that sort of alignment. And this one, honestly, I guess I just got lucky, So I think, that's kind of where we really need to kind of get a little bit more understanding about when we need to restore regional alignment and when it's better to maybe do something less aggressive from the original surgery. And so finally, I think piggybacking on that idea is the patient-specific considerations, which Dr. Shaffrey just gave a great kind of talk on as well. And I think the age is probably one of the more important factors in terms of how much total correction we want to get. We know that the thresholds for association with disability change with age, right? And so our targets for deformity correction should also be changing as well. Off the ISSG data, we have the sagittal age-adjusted scores, which have been shown to correlate with rates of proximal junction kyphosis. And so this patient who was in her 70s with a significant sagittal and coronal plane deformity, initial postoperative x-rays from, if you look at a C7 plumb line, looks pretty good. But you can already tell on this initial x-ray, I actually put this patient in a collar after surgery because I'm already a little bit worried on the first x-ray. And she was overcorrected, and she's kind of using her compensatory mechanisms and immediately goes to proximal junction kyphosis within 2 months of her original surgery and has to be extended up to C2. And these are the things we want to avoid, especially in older patients where overcorrection can be so fraught. And so that's kind of was showed with the data from the sagittal age-adjusted scores, where the rates of proximal junction failure are higher in the overcorrected patients, especially based on their age-adjusted targets, and as well as PJK in general being higher. And then the final piece is kind of modifying our plan or not offering surgery in scenarios where patients are just not going to be good surgical candidates because of medical comorbidities and severe frailty. Obviously, if we could all kind of create our own surgeon-specific risk stratification, I think that would probably be the best thing, although not very many people have the clinical volumes of a Chris Shaffrey or Lawrence Lenke where they can kind of create their own risk stratification. So we're kind of going to be, I think, risk calculators using generalized data is going to be kind of very helpful, and honestly, some of the work that Chris Ames is doing on this topic. And I welcome our AI overlords as they come to tell us what surgeries to do moving forward. But I think it's important, is that the AI is only going to be as good as the data you feed into it, right? So we have to be making sound, good clinical decisions now to help ourselves really in the future and our patients in the future, and continue contributing to the data. So those are kind of some of the factors in my mind for sagittal plane correction using posterior column osteotomies. And thank you.
Yeah, Alex, that was a really fantastic talk. You showed many similar cases and treated differently and got fantastic results. So I totally agree with you in that, a lot of the data sets, whether it's SG, ESSG, whatnot, every surgeon's different, and, what they can do or you can do, your training background is all different. We really need the sort of surgeon-specific data set. I think some of the, current technologies different companies has to help us to, on an individual basis, to predict, what outcome you can have in your own hand is very helpful. Can you comment on that? And
yeah, I mean, I think that's certainly kind of the thought and hope and dream of a lot of these companies now. I think, when you talk to the people from UNIT or SMIO now, right? They're saying, oh, we have these huge, the Metacrea, we have these huge data sets, and we can tell you this type of curve. If you correct it this way, you'll likely get that outcome and things like that. But I think that's a big point, right? The problem with big data sometimes is that the generalizability of a data set that has a lot of different data inputs into it might not be specific to the individual surgeon, right? And so as a surgeon progresses through their career, if you're starting with that piggyback of accrued knowledge from multiple different surgeons, right? I think it then becomes easier to sort of kind of train it to kind of what it means to you, I guess would be the best way to put it.
yeah, and your point about having good data is really important. I mean, so Chris Eames, he present that in the newest study with AI, the sagittal parameters is only 6% of the contribute 6% of the outcome, right? But in our clinical experience, I mean, if you put someone flat or didn't really do enough, I mean, they're gonna fail pretty quickly and they're pretty miserable, right? So I think that kind of goes against the clinical sort of observation a little bit. But I think we had this discussion offline is that if you have a data set of most people are reasonably well corrected, of course that factor is going to be less impactful to the outcome because you don't have such a variable
right
in that. Right?
Yeah, I think that's a great point. Kind of the idea that if you have a data set where like everyone's getting within maybe 5 or 10% of the goals in terms of sagittal and coronal plane correction because they're all very good surgeons, right? The difference between getting to a 90% perfect and 100% perfect probably has very little to do on outcomes when you compare it to medical issues.
Alex, great talk. It's just, it wouldn't be fair to not ask you a question about one of your colleagues down that was in your area. Since it's Hawaii, you have to ride the wave. And riding the wave always brings back Neil Anand, and who has a very different perspective on how much correction is actually necessary to achieve an appropriate outcome for a patient with spinal deformity. And in doing less surgery in a different way, although achieving less of a perfect correction, you end up trying to stay away from the morbidities associated with the big surgery. So how do you compete against somebody like that? You might end up taking care of his complications, but the fact is that all the patients go see him for the first time around, and it's very easy to convince a patient that I can do your surgery and you don't have to deal with all that stuff.
So first of all, I love Neil Anand, so that's my disclosure on this. He's actually a great guy, and I respect him a ton. Obviously, he comes from it from an extraordinarily different view. And the patient population that he's treating in general is a very different population, right? the patients that he is treating with multi-level laterals and honestly getting very good sagittal and coronal plane corrections with multi-level laterals. He's a meticulous surgeon with his technique. And, we all see each other's x-rays, in the area. So, but he has open disc spaces that he's working with. And a big part of his theory, I don't want to 100% speak for him at this meeting, but is that if you can just put the disc space back to where it used to be, kind of undo the degenerative process for a degenerative deformity, that's going to be good enough. And in most cases, it probably is, right? I think the situation where you have patients who've already had multiple previous surgeries, they have an iatrogenic problem or previous trauma, and the actual bone itself is the driver of the deformity, I think those principles kind of fall away. And I think he would agree with that, And so, we all have our own little different subspecialties and things like that. And so it's kind of fun being at a place with so much innovation and kind of being the one who's maybe, again, a little bit of the dinosaur amongst the innovators.
Thank you.
So over here, just great contribution to the program and terrific perspective on what's appropriate for surgery. As you know well, there's a spectrum of things we can do for the patient with deformity that may range from a decompression alone to more of a limited fusion to a more extensive fusion. And you showed some examples where doing something smaller didn't work very well. Having said that, when you own your own ASC, and when you want to maybe optimize your 90-day, right? The NIST group calculator gives us 90-day risk. So if I do a 2-level fusion for somebody with a major sagittal plane deformity, I do to my ASC, I do a direct lateral 3 to 5 and posterior, send the patient home the same day. At 90 days, there's not going to be a readmission. There's not going to be a reoperation. There's not going to be a major complication. At the same time, I certainly didn't improve that patient's quality of life. So how do we bring outcomes into the equation? Because right now, we're getting so focused on the metrics of performance in terms of complications, readmission. But to some extent, I'm actually incentivized in so many ways to do something smaller, to operate in my own ASC, to maximize profit, and to avoid a 90-day complication, which I'll always do with a single level fusion. I don't think we've had a readmission or reoperation for a primary decompression or single level fusion in years right now at UCSF.
That brings in a lot of topics to a point like that. I think the first part is that addressing in some scenarios, if you're assuming an honest, good clinician, honest broker, I would say, there's a lot of data saying that selective fusions in certain scenarios where the symptomatic level or 2 levels, even the setting of a deformity, can give sometimes similar reoperation rates to doing the definitive T10 to pelvis, right? So sometimes we'll say to a patient or in a meeting, that we have to do the definitive deformity correction because we want to avoid the next surgery, right? But this comes out of your institution, actually. The literature saying selective fusions actually have pretty similar reoperation rates to the T10 to pelvis and the T2 to pelvis, right? So from that standpoint, I have nothing against kind of trying to treat with less invasive measures, and I do it in my own practice in specific scenarios, right? At the hospital, I don't work in an ASC. But I think the second part of it is that the way we're being judged sometimes as surgeons in terms of long-term outcomes for patients is not helpful, right? We have a lot of papers looking at 90-day issues and 90-day complications because that's what insurance companies care about, right? And a concern I have is with ASR, right, which we're trying to get involved with. We're getting involved with that at Cedars as well now. And it also kind of seems to be capping at 90 days as well, right, in terms of a lot of their outcome measures, right? And so I think what we really need is good data with long-term outcomes. And how you get that is difficult. Some of the insurance databases and Medicare databases can do it, but then every time someone changes insurance, we then lose it again, right? So, that's kind of why the Norwegian countries sort of knock our socks off on the research long-term outcome stuff that you brought up in terms of the spondylolisthesis, and there's a million other papers that they've written kind of doing a great job with that.